it right now?
Wonderful, wonderful.
Thank
Perfect.
you. Sorry about that. All right. So if you just realize that if you unmute yourself, basically there's like a large room and you're on speaker. That's all.
Whoop whoop. Good morning.
Good morning to you, Johannes. Okay.
I wanted to take advantage of this that I'm on speakers, you know, but I mute myself now.
Thanks. So sunny greetings to Switzerland, I guess, then. And to the Netherlands and to Germany and to wherever you are all from. Welcome once again, the wonders of digital technology, right? So welcome from our side, from beautiful sunny Valletta with, I think, 26 degrees and no clouds in the sky. Hope the weather is as nice as where you are all from. Thanks to Digital Health Malta for organizing this conference together with us. And I would say we just jump in because I think we're quick behind schedule right now. I would like to give you just a brief overview of who we are from Germany. So I would like to introduce to you the Leibniz ScienceCampus for Digital Public Health and their Early Career Researcher Academy, from which we are all from here. So the Leibniz ScienceCampus Digital Public Health was funded mostly because we have this problem. So there is technology which is developed, but it's unfortunately not developed most of the time because people need it, but because we can develop it. And that obviously leads to some issues in terms of ethical, sociocultural, public health, and especially equity related issues. Because not everybody needs the technology, but it's there and it's not suitable for everybody. So this was the main problem that the Leibniz ScienceCampus, also called LSC, would like to address. To do that, we have 4 years. So we were founded in 2019, just when COVID hit us and stopped us from actually doing what we wanted to do, but focused us more on digital public health and COVID and disease surveillance. We were founded and funded by the Leibniz Association with 900,000 euros per year. And here you can see our the people behind the scenes, so to say. Those are organizing all of the Leibniz ScienceCampus and are the speaker and deputy speaker and the board of directors. So we have 4 aims within the Leibniz ScienceCampus, and those also give us the structure of research clusters. So every aim has their own cluster and their own goal to address. So cluster 1 aims at developing a framework to describe digital public health technologies and to cluster that. Cluster 2 looks more at developing and describing technologies and in terms of user-based and user needs. Cluster 3, in which I am in, is more interested in how to evaluate digital technologies, because the process is quite different compared to analog interventions. As you know, digital tools develop much faster than analog systems do. And the last one looks at strengthening and user engagement, and also looking at participatory approaches within developing new technologies. So for the 4 years of our funding period, all those research clusters are there, and also the Early Career Research Academy was funded just right at the beginning. And then throughout the ongoing time period, we have not only 6 PhDs as they are on the slide right now, but we now have the opportunity to have 7 PhDs. Because, you know, COVID hit us, no one was able to travel, and now we have quite a bit of money left. So we were like, okay, let's hire a new person to help us with fulfilling our goals. Last but not least, we also have seed money. Seed money is understood as we're financing one person for a year, in which they have to come up with a grant proposal for a project on digital public health. Because normally this time is not paid, but we have the opportunity to actually pay people to come up with amazing proposals to then fully finance a new PhD position. So now let's look at the members. We have 3 main shareholders, which you can see on the bottom of my slide. We have the BIPS, which is the Leibniz Institute for Prevention, Research and Epidemiology, which is driving the whole Leibniz ScienceCampus. And we have the Fraunhofer Mebis, who is an institute of digital medicine. And we have the University of Bremen. The university actually has 4 of its faculties included, because as public health is in Germany, it's mostly just public health people doing together and working together, which is obviously not the reason and the goal of public health, and it's interdisciplinary. So for this campus, we said, let's involve everybody who can do anything with digital public health. So we have the people from the computer science department and mathematics, mostly the human computer interaction dudes. We have the people from the Department of Law. We have folks interested in ethics and cultural studies, and of course also those from public health and from health sciences. So this is the Leibniz Science Campus. I would suggest that we have a quick look at who we as the Early Career Research Academy are. We currently have 40 members, and you can see they're spread throughout all of our clusters. However, we also have 6 people that are currently in no cluster, which is because they just freshly started and now have to come up and define a project and then find a cluster that they feel comfortable with working in and contributing to. Just yesterday, we finalized the new version of our mission statement, which we are very proud of and very happy that we did that. The mission statement is now clustered in 4 sub-statements, so to say. The first one is the one that's driving us. So it's the interdisciplinary collaboration, now knowledge transfer between different institutions and different disciplines, which offers us the opportunity to network within and beyond digital public health. The ECRA also is a platform for self-organized networking events like this one. We're also offering workshops for our members and give the opportunity to practice their science communication on various platforms. We would love and always do that. We do empower our members to actively develop their career skills and therefore give them also funding opportunities so that they can then participate in organized workshops, guest talks, or even stay abroad if they wish to do that. So we have 30,000 euro every year, which we can spend on our career development and on skills that we need to fulfill our research goals within our projects. Just to give you an idea of what we all did within the last 1.5 years. So this is just a brief overview of all the workshops that we did. So you can see we're focusing a lot on academic writing and the written communication of our science results. We're also talking about method development and how to publish and where to publish. And probably for me, the one that I like most and also think is most needed is the self and project management. We also invited some guest speakers and hopefully have to have some more people too. So Mariam, see you here. Hope to have you on board soon together with Petra for a talk on your amazing project. And last but not least, the probably most awesome guest speaker that we have is all of you as part of our network conference. So all of that being said, for all of you who do not follow us on Twitter, please do that. And I hand over to Stefan now to give you all an overview of what Malta is doing in terms of digital public health.
Thank you, everyone. It's been quite the morning, but don't worry, we'll have a lunch break and we'll all forget it basically in no time. In the meantime, I'm also over my AirPods trying to see that I actually can hear myself, just to check things. But so this is my story. I am wearing a couple of hats, as you might have realized. All right, so I'm here today with you as Health Malta, as one of the co-founders of Health Malta. I'm also working with my colleagues, Dylan and Ryan, Dr. Dylan Attard and Dr. Ryan Crack. And they are mostly focused on MedTech World, which is a conference which is going to happen later on this year. And that's happening quite soon. I'm also, my full-time job, the one which brings as the expression in Maltese is bread on the table. you know, even though I'm barely eating bread right now, as Laura knows extremely well. But basically that's my full-time job, where I work in the COVID-19 public health response team as one of the co-leads of the data management and information systems. So data is my daily bread and butter, so to say. But I'm also the vice president of the UFA Digital Health section. I lecture on digital health at the University of Malta. It's as if I don't have enough to do already. And I'm also working with the World Federation for Public Health Associations as the students and young professionals representative. So quite a lot to do. So I have to hurry up. But I'm also working with the Malta Association for Public Health Medicine, where basically I'm their digital lead. It's not an official post, but basically, you know, if there's something with the website wrong, I fix it. If there is something which has to be set up, I fix it. So it's that kind of approach. That's what happens in digital public health. So, oh, wait a minute, I wanted to show you something cute. And I don't know if I can actually show it to you. Let me see. Oh, it actually works. So that is like a doodle of like quick on the iPad, just to show you how important it is, not simply just to focus on the technology, but also on the human aspect behind it. So today I highly encourage you to use social media. All right, so those are the 3 main user accounts that I'm focused on today. And I really highly encourage you that we start getting the conversation going. The great thing about academia is the fact that, you know, we can start the conversation going, especially on Twitter. So what's digital public health? Is it just technology? I think it's more than that. I think it's a social science which is focused on effective communication, problem solving, change management. You also have to exhibit quite a lot of resilience. I know that resilience is like the top buzzwords to use right now, but resilience is really the key. Because if you fail the first time, like really what happened in the first part, we actually didn't do a great job, but then we tried again and we managed. So digital public health is all about that. First time round, you'll struggle with your stakeholders and they won't buy in. Second time round though, they might say, this is interesting. Maybe we should do it. Boom, then a pandemic happens. And then they really have to take up your digital public health solution. So that is the approach that we need to take, you know, like focusing on behavior change, bigger picture thinking. So, you know, you all have your research there. But if you don't focus on the bigger picture, you might get demotivated after 1 year of studies and just might decide to quit. But focusing on the bigger picture will help you arrive to the final goal. The same with exercise. If you want to lose weight, you don't focus on that particular moment, but you focus like 5 months down the line when you look better, when you will feel better. The same with digital public health. So that when you have an outcome and a vision for information systems, for real-time reports, you focus on the bigger picture. All right? So it really and truly is about a paradigm shift where we look at digital health, public health, not as being digital public health, but just public health. That's all. It's normal. But since we're all about digital, let's speak a bit about the disruptive technologies that we have underway right now. And these are 8 disruptive technologies, which were put forward by PwC. As you know, it's quite a popular consultancy. And they focus on these 8. I'm not going to go into the details and technicalities of each of these technologies, but there is a lot to think about. But taking into consideration digital public health, I'd like you to reflect a bit on the digital health ecosystem. And this is a small graphic I came up with. Okay, of course, it might be outdated in 1 year's time because of the constantly evolving ecosystem. But what we're looking here, We're looking at all these different technologies coming together, and in the center of it all, the main healthcare stakeholders together in equal partnership, with the focus being on being included in the conversation. Patients being included, not at the center like a puppet. Hello, you're speaking about me. No, it's about being included. Oh, yes, I like that treatment. Oh, yes, I like that approach. How can we do it better? Because it might be a bit painful for me. The same with digital public health. It would be extremely painful to input all that data. Can we pull it from another system? That's the pain that we face in digital public health. Oh, you know, but come on, I have to hurry up because I have 100 COVID-19 cases to deal with today. How can you expect me to write about each and every case? No. You had that person, you see where the data linkage is, pulling data from a demographic system, pulling in data from a syndromic surveillance system, which is manned by a helpline, and bringing the information all into one place so that public health professional focuses on what really matters. I think it's on purpose, this sound, you know, like it's exactly on point. So it's useless being here today without speaking about the COVID-19 pandemic, because we faced it and it was a big change. And I think that there were 4 main wins with the COVID-19 pandemic. That is mobile apps. Today, this morning, for example, when I checked your certificates, I used a mobile app to verify it. That's a big win. Data science and data flows. Now we see the importance of data flowing from one place to another, not being in silos. The silo mentality, I think, partially had a contribution to the morbidity and mortality of this pandemic. That's my assertion. I need to prove it. But it did play a role. The fact that for example, in specific countries, I won't name them, did you know that they faxed COVID-19 results in a specific country? I won't name it. That's crazy when you think about it. If they had to wait for a fax, that is not acceptable anymore. We need to look beyond it, and that's why data science and data flows had a big opportunity. And continuing on what I'm talking as well, there were digitalization, communication, and even operational changes, the way people work. So digital public health is not about the technology once again, it's about people changing the way they work. Whereas before they used to fill in a piece of paper, now they fill in a form, an electronic one. Whilst before they used to fill in an electronic form, now they access an information system which pulls data, relevant data from different systems. And last but not least, human resources and digital infrastructure. Whereas before we needed more data inputters, now we need more data analysts. So, as you know, these technologies all had a big win. In Malta, we set up our very first telemedicine center. We also had our contact tracing app, our very own, called COVID Alert. And we also collaborated with the European Union, specifically the eHealth network, where we made our app interoperable even with the German app. Quite cool there. So right now it's still ongoing. So if you come here to Malta with your German contact tracing app, it will still work in Malta. It's quite cool, right? And one of the biggest wins that we had is the idea of dashboards, having the information and data visually appealing and visually understood. A dashboard is easy to understand, like the dots. Oh no, like in the US, there was a concentration. These things, these visual cues, which some of you alluded to in your research, is visible there as well. GitHub and open data, having it available there. I think before we didn't even used to dream having some of this, but now it was all there. The Netherlands having, for example, very interactive dashboards which can be understood by everyone. Vaccination data. The World Health Organization taking a lead through specific software such as GoData, which we actually use in Malta as well. It's an outbreak management system. In Malta, it was more focused on case repository and having one place for all the cases. It was critical, it was important. Even WHO launched the first ever WHO Infodemiology Conference. Now they're going into the second and even third. So this is something that it had to be brought forward because of the pandemic. In Malta, we had a system to book as well your COVID-19 vaccination. This is a screenshot of way back when it was open up for 30 years and upwards. Now it changed. This is the place where to generate your vaccine certificate. I use pretty much this on a daily basis to help different people. And also the swab certificate as well. So the test and recovery certificate. And with that in mind, you know that we were talking about the EU digital COVID certificate, okay? And there were a couple of verifier apps. In my opinion, the best one actually is from Luxembourg because it works on all devices. And it's pretty amazing how you can even use business rules of different countries. This is the one from Italy. And this is extremely popular because right now, without this, you don't go and have your favorite carbonara in some restaurant in Firenze, for example, because it's mandated. So definitely this is one of the most popular apps. For some of you as well, the Swiss app, also quite cool. And it actually it has two versions. It has the mobile wallet where you store your certificates. And it has as well the check. So this is for people who want to check your COVID certificate. All right. Then this is actually something beyond the European Union, which is COVE, which is a South Korea vaccine certificate generation app. And there's also the verification within it inbuilt. And it's actually based on distributed ledger technologies. Not bad, huh? Not bad. Something also very interesting, and this is more focused on frameworks, is the Common Pass. And this is focused actually on the Smart Health Framework, where they also set up what is known as the VCI Charter, Vaccine Certificate Issuers Charter. And what's really good about this? In Europe, somehow this didn't really get along. Somehow we were more focused on using the EU DCC, which is focused on public keys and the public key infrastructure for multiple reasons, which I won't go into. But this is actually the issuance certificate platform that is being used by Apple and Google. So how will that change the way that we store our certificates? Are we going the Apple and Google way with using the Smart Health Framework, which is used by more than 100 million people in the US? Or are we going our own way? That's something interesting to follow. Now, imagine we had to deal with 27 different vaccine certificates and verifiers. I wouldn't have slept in the night, I promise you that. So many different, there are already permutations as is right now and things going wrong in different countries sometimes. But imagine a situation where we had a different custom application for every country. That would have been bloody crazy, I'm sorry. And that's why it's important to have a digital public health vision and a public health vision, because policy approaches intersectorially and across member states makes life easy for everyone. How much easier it was me for this morning to use this to scan all your certificates extremely quickly, you know, and allowing you to travel. It's amazing, you know. So when we come together and when we do like joint efforts, we can really do amazing things. Some in other efforts, such as the IATA Pass as well, the International Airline Travel Association, where they focus on creating a pass which also accepts vaccine certificates, but also test certificates. So like one place as well. So there's another effort going on. But with that in mind, I also want to kind of explore a bit how the different tech companies got into the whole picture. But one main company that really got into it and really invested energy is Microsoft. And even in Malta, for example, from scratch, we set up 2 Dynamics 365 applications, which have basically allowed us to sleep at night because they're scalable, they're robust, they're reused by companies with large number of transactions. And now we can use it even in a public health response, where we had to scale up extremely quickly. And it's thanks to the systems, really, that we were able to move fast, take quick decisions, and even come up with real-time business intelligence using something as Power BI. Imagine to come up with a report before, you had to extract the data from a system, put it in a report, upload it, and get it done. Now, it's all about designing the report and the data being queried in real time. Now, the next big challenge actually is to get that data, because there's so much data, putting that data in a separate reporting server so that it doesn't affect the performance of the main system. That is now how we're looking at. And we're scaling up in the same way that the tech companies, the big tech companies, have already scaled up. Now the big tech companies and all this, they're now looking even more into real-time streaming data. Data coming literally every second. Now, public health, that's going to be our next big change. And when you have all of these, then you can build applications, which are quick to deploy. You can build automations, and you can even build virtual agents and chat solutions so that you can interact quickly. Data is everywhere. And there are a couple of examples. And if you just have a look at this, we're looking at influenza, social media, public health related communication, disease staging, diabetic retinopathy. It keeps on going and going and going, the list. But we're not alone. The World Health Organization is focusing on these, on building the understanding of digital health. And like 2 or 3 presentations ago, there were the first 2 documents. And now there's actually a new document, which is focused on creating what is known as an info structure. I like the word a lot because it's a new word, like yet another terminology to get used to. But these documents really provide a good basis and understanding of how to create scalable public health information systems. And not just information system, but also apps supported by platforms, integrated with systems, bringing value to the individual. But I also want to show you my other hat, which is that of the European Public Health Association. And the European Digital Health section within the European Public Health Association worked on a number of things, a number of papers focused on public health digitalization, or focused on objectives of the section, and even on the potentials and pitfalls. We came up with this framework, which you can look at your own time, and we even came up with some pillars on how to move forward. So what is the potential of all of this and kicking off this journey so that I can also kind of close off as well? We're looking at the new way to do public health, a better way to do public health. Public health which is not simply informed by the narrative and what's happening on the ground, but also informed by data. How powerful is that? Data plus narrative, a powerful combination. But how do we get there? And I would like to propose this non-academic, non-validated, non-peer-reviewed framework. And it's called the Spice Spot. It's meant to keep things a bit spicy. All right? But what is it focused on? It's focused on supportive digital health ecosystems, clear procurement pathways, an innovation framework to support your work. It's useless going out there with a new technology if it's not supported by a framework, by standards, because it will cause even more confusion. If you have an information system which comes in with new standards, and just to give you an example, imagine having two systems that have to communicate to each other, but they have localities and regions, for example, totally different to each other, because there isn't a standard. And even though you can map and you can create data linkages, how much more powerful it is to create information systems which follow a framework, much more powerful. You'll be even quicker in analysis, and you'll be quicker to even reach your operational outcomes. But last but not least, we're also looking at behavior change and intensive education and awareness. My invitation to you today, you can make a difference. One course at a time, one talk conversation at a time, one social media page profile at a time, one website, one business intelligence dashboard, being able to do it yourself because you are capable, one app at a time, and possibly one new Wi-Fi network where you go work in a public health department and they don't even have a Wi-Fi network. And you go there and get it done. All of a sudden, you have created a dynamic workspace where people can work from different locations and they can talk to each other even. At the end of it all, I want to invite you to be ready to jump at the right time. We have to be at the table and not just on the menu. Thank you. Okay, so our next big challenge is to get the posters up and running. So one moment. I just would like to confirm with our, let's see if that works. 1 second. So now this is going to be our next. Okay, can you see the posters, please? Can someone do a thumbs up from the, or just unmute and say if you can see the posters or not, please? Can someone please answer me back from the Zoom call, please? Okay, we've got a thumbs up. All right, so first up, development of study design for a self-evaluating mobile phone application. Go for it. If you can, since I don't know you, it would be appreciated if just name, surname. That's all, just to get to know you. Cheers.
Okay, we had a great talk and now we just jump into concrete projects. And I'm starting. So I'm Paula Boskamp. I'm a PhD student at the University of Bremen. And I work in the field of statistics applied to medicine or epidemiology. And in my PhD project, I want to develop a new study design for a mobile phone application, or we just say app usually, yeah. And specifically for apps that are interventions to have behavioral change. For example, we could have an app that wants to increase physical activity for its users. Yeah. My goal is for this design to have a fast and efficient method that is suited for this specific kind of intervention. And yeah, I will use different concepts here, but the main idea is to use so-called N of 1 trials. N of 1 trials are studies with only one participant. So we have a within subject design where this participant will get different interventions, not at the same time, but one after another, and not only once, but multiple times in a randomized order. In this way, we have different time slots we can compare for this subject and can see, okay, what is effective for this one, for this people. And when we apply this in the app, we can have the different app components and yeah, vary them so that we can see if they're effective or not. And so we can not only evaluate the app overall, but see what really works within this app. Yeah, that's the main idea. So, are there any questions? Do we have time for questions? Paula.
Are there any questions for Paula?
Are there any questions?
Okay, I don't think so. Okay. Okay, you will get the posters later, I have just thought. So if you have any questions, you can contact me. Great.
No, the one before. Yeah, that's it. Right. Thanks. Yeah, thanks, Paula. Thanks, Stefan. Thanks, Digital Health Malta, for the chance to speak here. It's a nice opportunity for a young researcher like me. My name is Hans-Henrik Dassow. I'm from the Institute of Philosophy of the University of Bremen, and my general interests in academia are in moral philosophy, the philosophy of law, and political philosophy. And some few words, a short briefing about my PhD project. It is about the ethics of digital public health interventions, and especially about health apps. And I have a distinction made right now in my research progress. There are once the apps in the individual use, and the other hand, the apps in the digital public health context. And from my point of view, from an ethical point of view, there are many conflicts arising, normative conflicts, and I want to lighten those conflicts. And in the first step, I want to categorize health apps, because I think it's not, well, reasonable to discuss every single app on the App Store from an ethical point of view. Maybe we have to categorize them. And I tried in terms of their functions for users and for health systems. And as a result, like Stefan mentioned, what is the big picture? I want to hand developers and also users some ethical standards, some principles which may guide them in their daily lives, in their workplace, whatever. Some ethical implications I want to discuss are like data protection, efficiency, equity, functionality, whatever. There's big ethical fantasy around us, and yeah, I'm very happy to present my project here. Thank you. Yeah, are there any questions? Is there a chat, or I don't think so, right?
Okay. So, all right. So, quick question. When you're looking at ethical standards, are you looking at a document? How are you going to communicate this, for example, to health app developers? How it's going to be practical for them? You know, mostly sometimes they're just focused on the code and that's it, you know? So how are we going to communicate this?
Through like conference like that, being on Twitter, something that's like the point of science communication in general. I guess there's not that one approach to make the population more ethical in their behavior. I guess that's the public discourse, and somehow ethics or philosophy in general has to, yeah, as we say, intervention there. And it's a point of science communication, what I'm quite learning through ECRA and the LSC.
Good morning, also from my side. My name is Daniel. I'm a PhD student in the field of human-computer interaction, and I'm very happy to present this project we did together with Tina, Rihanna, who I think are also joining us virtually, and Johannes Schöning and Benjamin Schütz. And what we did is we looked on how we can reduce the sharing of misinformation on social media. So we all heard about the term infodemic, which Stefan actually introduced earlier today. And this is an overabundance of information related to COVID-19 that is both correct and wrong, but it's very hard to distinguish. So people are confused, they don't know what to believe on social media. And one thing Twitter has already done is they're working together with fact check experts that help them to classify right and wrong information. And this has been shown to actually backfire. So people, when they see those flags, they tend to increase their beliefs in both the right and the wrong direction. So a problem in that case has been that there has been a lack of conceptual clarity and evidence base in such social media interventions. So what we did was we employed frameworks and an evidence base to develop a social media intervention on Twitter. So we developed a Chrome browser extension that triggered when people tried to share misinformation. And they were shown a little nudge message that showed them, your Twitter network has mostly ignored this tweet. Do you really want to share this? And we combined this nudge with a misinformation flag. So that means that on top of the social nudge, there was also the information that they should not, that fact checks have been done on this and they should not share this. And this has been shown to be the most efficient way of stopping them to spread this misinformation. And what we think was a very valuable lesson that we learned is that we actually were able to observe behavior. So compared to many previous studies in the field who only looked at intentions, through our methodological approach, we could actually see, okay, those people, they try to share this, and our nudge could reduce the amount of misinformation shared. So yeah, that was a success in our opinion. Thank you.
Other quick question for you. Yes. Have you looked at other social networks, not just Twitter, since a lot of other people are on Facebook, you know?
Okay, thank you for your question. So I have to say that this was more of a technological question for us, because for Twitter, it was quite easy to develop this Chrome extension that basically hooked into the tweet. And for example, Facebook is a lot more restrictive in that sense. So that's why we started with Twitter, but we hopefully can also continue.
Okay, so I have a question actually from one of the reviewers of the Frontiers in Public Health, Digital Public Health. I'm going to read the question from Angelo. If you want, Angelo, do you want to try and unmute and ask it, or can you try? Okay. If need be, I'll read it for you. No worries, Angelo. So 2 questions. How do you convince the people to get the extension? And how to avoid enrollment bias? Those are the 2 questions by Angelo.
Thank you very much, Angelo. I think I can answer both questions with one answer, hopefully. So this was an experimental online study. So we did observe behavior in the wild, but we still use a recruitment platform. So this is prolific in that case, which means that, yes, there was obviously a bias. So for example, we had, I think, 2/3 female participants, which does not reflect on the actual Twitter population. However, we did not, for example, only included participants that were sharing misinformation actively, but we only invited participants that had a very active Twitter account, which I think is okay, because those are also the individuals that share most misinformation on social media.
Fantastic. It's time for the next presentation. Thank you very, very much.
Thank you. Thank you.
Can I start? Okay. Hi, my name is Stephanie, and I'm on behalf of my pen project, which is funded by the JPI ADHL. And today I'm going to present the development of a consolidated approach for a pan-European health surveillance. So why did we actually start with a project in our surveillance and monitoring project? The first thing was there are so many different action plans or policies in terms of changing health behaviors, but there's actually a gap in developing harmonized instruments. So across surveillance and monitoring systems, there are non-harmonized instruments. So our idea was to have comparable health indicators, but also on top of that to make use of digital instruments such as accelerometers to measure physical activity more objectively. To do that, we first started off, as you can already see in the first box, with a prioritization of health indicators in terms of physical activity, and we did this with experts and also surveillance and monitoring representatives in an iterative process. Second, when we had the indicators prioritized, we collated them and put them onto different European databases to identify prioritized indicators. And we put this on the PEN webpage, which is available on the QR code, or you can also visit the PEN webpage. Third, with this list of prioritized indicators, we developed screening instruments, short screening instruments for physical activity in terms of cycling and walking or physical activity recommendations. And we had those simple screeners that we call them because they are basically focusing on the multi-level and going down to the individual level, like measuring physical activity of an individual. When we had those screeners, we went to representatives of different surveillance systems like EHS or WHO STEPS or HBSC, and we were discussing them. And we also mentioned the use of accelerometers as an objective measurement to have high quality data for population health surveillance. And yeah, the last and fourth step would be to meet all together next year, probably in Brussels, to build an expert platform actually to advance and sustain the harmonization process and also discuss the implementation of accelerometers in subsamples of existing surveillance systems. And to conclude, our idea is to use digital measurement instruments to enhance European health surveillance. And yeah, this is the bigger picture, I would say. Thank you very much. So yeah, are there any questions for me? Yep. Okay.
So how do you plan to, once again, this is like prepare for this kind of question for all of you actually, but how do you plan to communicate this? How are you going to convince a public health professional to even use the website, like to get their outcomes? Like, what are you looking at? Like, are you measuring this in any way?
In terms of accelerometers, because usually existing surveillance and monitoring systems, they use surveys to collect their data. But we are going to convince them that it's more feasible and also more less costly. And also there's so much more data when they use digital instruments. And they, of course, they would not implement them completely, but they would start with subsamples. They would, for instance, pilot them on national level, and it would be a stepwise process. Yeah, to get there.
This going beyond Europe?
It could be, yeah.
I have to switch about that.
Yeah. Thanks. Hello, my name is Christine Döhler.
I'm an external PhD by the University of Bremen. Actually, I belong to the University of Cologne. And besides, I belong to the consortia NFDI for Health. NFDI for Health stands for the build-up for national infrastructure for personal health data. And in this consortia, I have a special task. My main task is to be a data stewardess. That's a blessing and challenging because there's actually no definition, no job description about to be a data steward or to fulfill the tasks of a data steward. So therefore, I decided to create my PhD work to build up a concept for data stewardship. So it's independent of the labeling data steward, data scientist, data architect, data hygienist, or whatever. So I adapted my concept to the Medical Research Council framework. That means I do have to fulfill or to create with my partners some main steps. And it's not like a circle in one way. You can go back to the steps before and can modify the measurements. And yeah, there is the chance to guide the researcher in the field. Especially for me, I have the pilot, the Clinical Center of Trials in Cologne. So I just want that there's a bigger picture for ethical, legally, and technical aspects, as well as to verification, to make data fair, or to think about repositories, or to think about systems or tools where we can data collect. It's for me much more than that. And so that should be my shortly introduction to data stewardship, and I'm happy to take your questions. Yes, please.
If you had only one sentence, what is a data steward? Like something that you can communicate quickly. One sentence.
For me, a data steward is a person who guides every researcher in ethical, legal, and technical aspects.
So, any more questions from the audience? One second, because we might have a question. Okay, all right. Wait. Oh, you can stay there though. So, a question from Angela. What would be a core curriculum for this figure?
I do, sorry. Sorry, I did analyze before I started my request for PhD at Bremen. I analyzed all the definitions about data steward, data stewardship, as well as job description, so that I could got a feeling what is the need of institutions, of universities, why they are looking for data steward, data scientists, and the curriculum. Or I think a good example was the data train by the University Bremen, the Research Alliance. But that is just one model. There are such a lot of models for curricula, and they developed, it's work in progress now.
Already some work underway. Fantastic. Next, okay, count me in.
Hi, thank you. Okay. Hi, and good morning to you all. Thank you for being here with us, wherever you are. So my name is Paula Sofia Herrera, and I am currently working as a researcher at the Leibniz Institute for Prevention, Research, and Epidemiology. As part of the Department of Epidemiological Methods, I am in charge of understanding how the recruitment and outreach of population-based studies, such as clinical trials, can be enhanced with with digital technologies. And yeah, so as you may observe on the left column of the poster, my research topic focuses specifically on the impact of machine translation tools for increasing response of culturally and linguistically diverse individuals and their communities, so that these studies can be less biased and more generalizable to the wider population. This is actually quite aligned with our mission of solving for equity and being socially relevant. And well, as Stefan mentioned at the beginning, this is indeed thinking of the wider picture and using disruptive technologies to improve public health operational outcomes. So, well, in short, my research hypothesis stresses that in highly diverse populations, as we live currently in this planet, where different languages are known and used with varying levels of literacy, distributing the same contact and recruitment material in one written language logically would contribute to the decline or absence of participatory engagement. And maybe by using digital tools along with machine translation technology, we can solve for this inclusion problems. And well, just to give you a brief overview of how my project is divided, it is basically planned in 4 big working projects. The first one consists of a systematic literature review of, well, knowledge that has been created up to now on how different digital language tools are used to solve for participation and engagement of specific target groups. And then secondly, we will create a prototype of a web app to apply it to the studies, and then we will apply it in the childhood obesity study from the World Health Organization. And finally, with the results collected, we will test to prove our hypotheses that these technologies are actually useful. So that's about it. If you have any questions, please do so.
Of course, I can't resist a question. I don't know something. I noticed in your poster that you've used a QR code.
Yes.
And definitely QR codes, it seems they're here to stay. All right, as you saw even this morning. So that's really fantastic. Just a quick question. How did it go? Did it get implemented in the European Childhood Obesity Surveillance? How did that go? Or how is that going? That's really, really interesting. Great job there.
Yes, thank you for that question. Okay, so well, the QR code is actually very easy to get. The QR code is very easy to generate. This is not a big problem. You just look for it on basic search online platforms like Google, and you link it to your web page, which is actually the ECRA, and specifically the one of my research topic. And then regarding working project number 3, at the current moment, I'm in working project 1. So I started a year ago, my PhD, and then eventually hopefully in the last quarter of next year, we will be working with the World Health Organization to deploy their local survey in Bremen. And this is basically answering the question you did before. This is actually what we do, is that we go to the schools. We have partners with the schools where the children are, and the teachers distribute the paper-based recruitment participatory form. Yeah, and then they can scan the QR code. And with the QR code, people can choose the language and the type of communication format that they would be more comfortable with. And this would hopefully help for people that don't speak German, for instance, to participate in donating their data for science. Yes, hello. Thank you.
Thank you. Thank you, Prof. It's yours, right? Yeah.
Yeah, but I have a cold, so maybe it's better to leave it on. Yeah, so sorry if you can hear me breathing. I have a cold. But my name is Neville Calleja, and I have a background in law. So I studied law with a focus on medicine law and informatic law. And my PhD project is about health apps. And the most problematic point of health apps, in my view, is informed consent, because everyone is just accepting data policies without reading the policies. So one could say that informed consent does not exist in the reality of health apps. And my aim is to change this. And therefore, I'm looking on 3 categories of health apps, like normal health apps, fitness apps, tracking apps, and so on. And then apps in the context of digital public health, like Stefan presented some COVID tracing apps and maybe apps from health insurances. And then I have another category of apps, maybe not a category, but what happens when companies are sold. So what happens with the data? And yeah, this is the basis. And the first step is to analyze data policies. And on the poster, there's a table and there are categories like how is the language, how easy is the language, are there dark patterns used when you give your consent? And yeah, this would be the first step. And then we have 3 models how to regulate health apps. One could be self-regulation, which is currently the case. So nothing is really regulated. And another approach could be a new model of consent. So new laws for consent. And another approach would be permissions, like an app could only assess the market if it has a permission. And these are 3 models that I will evaluate based on the analyzation of my apps. Yeah, so thank you. And are there any questions?
Watching the chat. So you know when you see actually privacy policy, you usually end up like having this long page, keep on going, and you have to scroll through all this to this document. I've seen really good case examples, for example, of privacy policies being indicated by highlighting the 5 main points of the documents. You are agreeing to this, 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 and this, and that's it. So the good thing is that there's some movement there going on already. But so your research, what would be the value on top of what is already happening? Like what is, if you had to summarize it in 1 sentence, how would you do that? Like what is the added value of your research on top of these very interesting things that are happening? Like, is it the legal aspect? What is it exactly?
Yeah, I think it is the legal aspect, because people are only doing things when there's punishment. And so this is the main aim, yeah, making it lawfully. So data policies and consent models on a legal basis, so that everyone has to react. Yeah. Maybe not 1 sentence.
Oh, that's great. Thank you. All right. Next.
Thank you. Hi, everyone. My name is Victoria Hu. I work in an EU Horizon funded project named Distinct. And without spelling out the acronym, I can summarize it with saying that it's about social health within dementia caregiving and the role of technology to promote this. So long story short, my project revolves around relationships and social health in a dementia caregiving context. So as we know, if someone has dementia, it's not only the person that is diagnosed who has their lives impacted, but also their family members, who then tends to take on a caregiving role as long as the person with dementia is still living at home. So we know there's so much evidence to show that a good caregiving relationship is crucial for the quality of life and well-being for both members of what I call the caregiving dyad, which is the care recipient and also the caregiver. We're now trying to look at how technology can play a role in enhancing the social health of both members of the dyad, because the better the dyadic relationship, the better the caregiver resilience, for instance, is, and which ultimately can actually delay institutionalization. So as a part of my project, I am actually working with Lars Steinert, that you will see later today, on evaluating a tablet-based activation system, specifically designed for people with dementia to do in tandem together with a partner. And in our project, an informal caregiver, a family member. So we're doing this as a mixed methods feasibility trial, which is currently ongoing. We're still struggling with recruiting participants due to, you know what. So right now we have designed the study to be home-based, so that the person with dementia can do these tablet-based activities, anything from image galleries to music, puzzles, and games, that they can do this together at home in a safe and easy way that doesn't require any specific training. And I'm then trying to assess if this specific tablet-based intervention actually shows social benefits for both members of the caregiving dyad. So we're doing baseline interviews and also questionnaires that are standardized and internationally validated. So we're also actually looking a little bit about how the COVID-19 pandemic has impacted these caregiving dyads. And then as the follow-up and the post-intervention interviews, we want to see if this tablet or the system called ECRA actually was beneficial for both the caregiver and the care recipient with dementia. Yeah. Any questions? I'm sorry. Does anyone have any questions? Yeah. Yeah.
So when it comes to, now this is purely a technology question at this stage. So if I may ask, what kind of tablets you're using there? Is it an Android tablet or is it an iPad? Because they have different needs. And the other big question is, how do you intend to finance it in the long term, such a platform? Would this become a business? Would this, like, what's the next step for ECRA?
Excellent questions, thank you. First question first, we're currently trialing this system on the Huawei apps, tablets, sorry. And well, right now this is a feasibility trial, so hopefully this can inform a larger scale trial with more participants. And Lars and I are currently in the works of trying to establish collaborations with the potential collaboration partners. And we have some interests both in the institutional setting, which, I mean, this system has great potential for, let's say, if we want to visit a loved one that is actually in a nursing home and you're struggling to find what you can talk about or what activities can you really do. So we really believe in ECRA and the potential that it has. So hopefully in the long run, this can actually be an offer to do both in the privacy of your own home, but also that's something that can be implemented in an institutional setting. I think Hans-Henrik might have a question.
I'm just gonna have to pass that.
Yeah, thank you, Victoria. I'm very curious about this app because my grandma also has dementia, and I'm kind of committed to this topic. And but you do research at the university. What does the private sector do? Are there any comparable apps on the private market existing, and what do you do in comparison to them?
Also a good question, thank you. We have talked with some self-help groups, for instance. We have had a lot of presentations where we showed them iCare, the tablet, and how it works. And just on the top of my head, there was this one woman who were there with her husband, and she mentioned that there was this one similar tablet, which was called, Lars, I don't remember what it was called. I need to get back to you with the name of it. Yeah, Media for Care, which sounds like an excellent offer, but also very, very expensive. So they hadn't stuck with it. Yeah, there are a lot of offers out there. This, maybe what I should have mentioned with iCare, what makes it special is that it also has a recommendation system, which means that there are so many different activities that you can do, which might be very overwhelming for either the person with dementia, but also their caregiver if they don't really have the tech literacy. So this recommendation system can really simplify the process of choosing content. I think Lars will explain more in his poster presentation. So I'll leave the mic here and don't take more of your time. Thank you.
Next, yeah, all right, we're moving, nice. Okay, just to give you some idea of the time, we're doing really well with time, okay? So, you know, like if you need to explain something, you know, or questions, now is the time, okay? All yours.
Yeah, that's mine. Thank you. I'm Lisa. I'm working at the Leibniz Institute for Preventive Research and Epidemiology called BIPS. And I'd like to present you the project ESTA. That is a cooperation of the BIPS and 2 other institutes and also 3 German public health departments that we are consulting. And our aim is to provide a digital tool to these public health departments to support them with their decisions that they need to do on quarantine and also on contact tracing. So far, we have developed use cases on the time periods of the COVID infection and also use cases on the transmission probabilities in group meetings. I brought examples that I put on the poster for both questions. Like you can see on the left-hand side, example, the question would be when did the person got infected? And on the x-axis, you can see the date. And the darker distribution shows that the person would be infected by 90%, no, by 80%, sorry, during these days. And the other example for the transmission probabilities, like the purpose for the employees at the public health department would be the support with their decision if the group needs to go to quarantine or not after this meeting. And we propose a 90% threshold that if you are aware that no transmission occurred at that group meeting by 90% certainty, the group does not need to go to quarantine in full. And the main task at BIPS, what we do is the evaluation of that tool. Like we are in contact with the public health departments and we're speaking to them what fits their workflows, what they need and what is adaptable to their software. We plan to do cognitive walkthroughs to adapt for utility, and we want to do also focus groups interviews to overcome implementation barriers, because the main goal would be to provide an open source software that is combined to the commonly used software that is already implemented in the public health departments. And yeah, the goal is to relieve the burden of the public health departments to make their work more efficient and more gaining. Thank you so much. And I'm happy to hear questions or comments. Anything?
So Lisa, quick question for you, because I can see this this decision support tool to be implemented either as a plugin, for example, to an existing software, or as an update to software already. That means that they would integrate it as well. So are you looking just at integrating, for example, with the Maaß software? Or are you looking at Go Data, for example, or other systems which public health professionals are using to collect data on outbreaks? And is it just for COVID? That's another interesting thing for you. Cheers. And then Angela has a question as well.
Perfect. So yeah, I see two questions in that. First of all, regarding the technological thing, the software itself, we are providing R packages. So it's written in R software. And by now we are trying to combine it to SORMAS. That's the one that will be used in most public health departments in the following year. Like by now, all public health departments do have the software, but also ServNet is used commonly. So we also try to adapt to this one. But in the long run, it will be SORMAS, would be the go-to software. And for your other question, was it right?
But we have, yes, Angelo would like to.
Yes.
So
can you hear me?
Yes, I can. Go ahead.
Okay. No, sorry. Maybe you said it. First of all, compliment for the presentation. Maybe you said it earlier, but I had to disconnect. So, in case it's a redundant question, I'm sorry. Did you say which kind of model did you use in particular? Which is the modeling stack?
All right, Angela. Lisa will answer.
Yeah, I did not say that before. That's a good question. And I need to say we are working with these two other institutes. These are mathematicians and data scientists. And what we do at BIPS, we do a systematic literature review to define and quantize the effect parameters, the fixed parameters in these models. And our statistician colleagues, they provide the models, they adapt them from the bottom up. So you can find it in the prototype. It's linked how they do that. They decided on a prior distribution in first place, and then we have additional parameters that adds up the risk.
Okay, so it's this Esther package.
Can you repeat that, please?
Okay, sorry. This Esther package is already online, available to see the.
No, that's our goal by next year to offer that.
Okay, because you said there was a link, but I wasn't sure.
By now it's a Shiny app. It's also a website, but it's by now it's just a demonstrator prototype version. We improving this one, and then we are offering the R packages.
Okay, thank you.
You're welcome.
Thank you, Lisa. So let's go. All right. Laura, all yours.
Hello again. Yeah, I am one of those 7 PhD students from the Leibniz ScienceCampus. My name is Laura. I'm a public health practitioner by training, and I am now evaluating the European healthcare systems in terms of whether or not they're using digital health technologies on a national level. So I'm not looking at those privately bought interventions like wearable Fitbits or apps that you can privately buy, but I'm looking more at what is the country offer for their people. And so what I want to do is come up with an index to allow benchmarking at the end of the day, to also allow countries to learn from each other. So it will be in a quantitative manner, to have it more or less easily calculated, so that hopefully politicians can pick it up later on and then use it again to evaluate the system as it's ongoing and evolving. So you see the umbrella here, and that umbrella is divided into 4 sub-indices, of which the first 3 are of quantitative nature, while the 4th one is of qualitative. So the first ones, they look at the technological readiness. Is there actually an infrastructure that allows us to use digital technologies on a national scale? Looking at countries where physicians needed to fax stuff. I think Stefan was referring to Germany when he said that. So cheers to Germany. That's the one thing, because you can't have digital technologies in health if you're not having the infrastructure for that. The second one looks at the legal framework. Is there any political regulation on data security to protect our patient data? The third one is then the actual use of digital health technologies, for which I'm currently doing a scoping review together with my 2 colleagues, Merle, who already presented, and Chanchia, who's I think up next, in which we're going to do that. And then the 4th one, as mentioned, is of qualitative nature, where I want to assess whether the people are actually willing to use that, because it doesn't matter if you have everything, if no one's going to use it anyway. So this is my project. What I'm going to research on until 2023, I guess, and I'm happy to have your questions if you have any. Thanks.
How can I resist? But the big question for me that I have for you is that in this the digital public health index, you mentioned readiness, specifically technological readiness. Are you going to look at the readiness of public health professionals? That means that the professionals who will be taking the technology, are you looking at that? Or maybe it's beyond scope of this index? Happy to have your thoughts about that.
That would probably be more in the 4th sub-index and the willingness to use it. The first one that is just focusing on the technological readiness. So if the country actually allows physicians to practitioners to use those technologies. Yeah. You mean for the 4th one? There are frameworks and models on how to measure willingness to use that. So looking at the technology readiness and acceptance model, the TAM and TREE, they are already applied for various health and digital health fields. But yes, there needs to be one which is trying to describe all of that. But I hope that Tina has that one done. Because she's our expert for framework development in the Leibniz ScienceCampus. Okay, then I hand over.
Hello, hello, hello. Yeah. Thank you very much. Thank you very much, Laura and Stefan, for organizing this. I'm Thomas. I'm a first-year PhD at the University of Bremen in the Digital Media Lab, and my focus is, what happens? Oh, there's too much. Bless you. And my focus lies on unethical design and in the online web, with a particular focus on social networking sites such as Facebook, Twitter, Instagram, or TikTok. And I would like to show you this recent study that I did together with Gianluca Savino, where we investigated the interface changes of Facebook in the past 16 years to find links between decreased online well-being and dark patterns, which are one of the categories of phenomena arising from unethical designs. And what we noticed was that Facebook chose to place very privacy and security related items much further in the background, the more modern the interfaces went. and thus hindering basically the discoverability of certain items such as logging out or taking care of your privacy settings. And we noticed that users actually found it much more difficult to have an impact on their own on their privacy and security settings. And what we tried to do with an online study with about 116 participants, thank you, was that most people are very much aware of their privacy and security in their personal accounts and what they want to protect, but are not able to actually place that in the web and in their accounts. And what we thought was, and this is like in the results section of this poster, is what we found is that Facebook has 3 different kinds of interfaces that actually make users or enable users to change the settings with 3 different kinds of usabilities and accessibility. And the most complex one is the just standard privacy settings, which people are not able to really navigate, whereas there are much more usable interfaces such as the privacy checkups that show only a very limited subset of all available choices. In my future research, I'm currently looking for similar phenomena in TikTok and Twitter, also in Instagram, and we found very similar practices. And now we try to link those to the well-being part. Thank you very much. If there's any questions, I'm happy to answer them. As this is the philosophy for this.
Other social networks?
As in TikTok, Twitter, Instagram, or as in YouTube and what else? So currently we are looking at Instagram, TikTok, and Twitter, right? I'm very interested in TikTok right now because it's very, very new and it has a very different approach to many things, but also to Twitter, which is a much more text-based interface, for example. It works differently. And so I'm trying to compare those, what is comparable, but it's very difficult. For example, YouTube, we've decided not to include yet, because it's a lot of effort to include any app, and I think Daniel knows what I mean. And the strategies of hooking users to the platforms is differently and changing. So yeah, I think it's going to take time to investigate all of them. So for now, it's only those 4. Yes. They are the most popular in their categories occurring to Statista. And with a category, I'm referring to so YouTube, for example, is a video-based interface. And what we were looking for was mostly connective social networks where you are actually bonding with others in group-based systems. Other questions? Am I seeing them here?
Angela, I'm not sure. Sorry,
okay.
Angela, I'm not sure. You have your hand raised, but I'm not sure if you had a question.
No, sorry. It was from the last presentation.
No problem. Next.
Thank you so much.
Thank you. Okay.
Thomas, yeah. Hi, everyone. My name is Yasmin. I'm a senior researcher at the University of St. Gallen, and I'm doing research in human-computer interaction. So I'm focusing on how we can design health and well-being technologies to improve the health and well-being of people in their everyday life. And for that, we focus on applying user-centered methods. And yeah, then we hope that we create positive experiences, positive user experiences, so that people can achieve their health and well-being goals. I'm involved in a bunch of different projects, and I brought some examples with me today. So for instance, one virtual reality application that we recently developed focuses on providing a positive psychology intervention for people in their homes. So they can do this to improve their well-being, to improve their happiness without any kind of therapeutic supervision. Another example I brought with me is in the work context. And here we looked into how we can get people to be more active at work, but not in their breaks, but when they are doing their actual work. So we are currently designing technologies for meetings in motion. So how can we do meetings while people are moving around, so-called walking meetings? And beyond that, we are not only applying user-centered methods to design new health and well-being technologies, but we are also focusing on developing new methods for this approach. So for instance, when we think about health and well-being technologies, they are often perceived as creepy or scary to many people. So what we did is we developed a scale so that we can measure as how creepy technologies are perceived, for instance, in the beginning of a user-centered design process. And what's cool about this scale is not only that through this, we can find out if technology should maybe be more socially acceptable, or if we have to design feedback options in a different way, but we are currently also developing a website so that practitioners can find out if the technologies they are developing are perceived as scary or should be designed in a different way. Yeah, I'm super happy to answer any questions, and thank you for being here and listening.
When I'm thinking of like this scary part, I can imagine like the Monsters Incorporated film, like, and I can imagine like a scale like scary or not. I don't know if you remember, but that's part of the fun. But apart from that, like this is really interesting. And my big question is, how are you going to measure emotions? What are you looking at? Are you looking at self-assessment? Are you looking at observation of facial features, or what are you really looking at there? Over.
So just to clarify, when we measure the creepiness of technologies, you mean? Yeah, it's a fascinating topic, so please stop me if I'm talking for too long. What we did as a first step is we did a bunch of focus groups, expert discussions, and so on and so forth to develop the scale. And right now it's a questionnaire where people self-assess how they perceive the technology. So we have 3 different aspects. One aspect is implied malice. So if I think this technology is harmful, and here it's getting interesting because it's also about the person behind the technology, right? Then we have one aspect that is focused on undesirability. So if there is something that is out of context, socially not acceptable, for instance, and then we have a third aspect, which is ambiguity. So I don't exactly know what this is. So what we often see with artificial intelligence. And our next step is going to be that we extend this toolkit basically, and we bring into the whole assessment also sensor data and qualitative observations. So yeah.
Thank you so much. It's fantastic, really. Okay, let's see. So, all right, there's some more to go. Come on. All right.
Hello, everyone. My name is Chen Jia. I'm a PhD student from Taiwan with a background in public health and a research focus in physical activity. And today I'm going to talk about my PhD project that is funded by LSC Digital Public Health. And my project is about the activity tracker that is operate on movement sensor, which is like a pedometer and accelerometer in both wearable, for example, like smartwatch or Fitbit, and also in smartphone that use a fitness tracker like fitness app, health app that also has the tracking function. So this has been very trendy and very popular, and also in clinical and practice that has been used as a health intervention in order to promote physical activity. And that has a great potential. But when we comes to designing an intervention to make it effective to change people's physical activity, there are still a lot of contextual factor that is unknown. So in my project, we want to look into who will be mostly benefit and like what kind of tool, is it wearable or is it smartphone, and what kind of behavioral change technique and what kind of health outcome and what kind of behavior that we can expect the most effectiveness. So we also want to use like through 2 systematic review and also a questionnaire to a cohort study. We want to find out what kind of individual levels of determinant. For example, it could be readiness to change and also their interest in technology or their body image perception, like what kind of individual determinant and what kind of social demographic can most have the association and the most benefit from this kind of intervention. And yeah, so I'm very happy and excited about my PhD project, and I'm happy to share more future results with you. And here's my email address. And does anyone have any question from the meeting?
Hello, everyone. I hope you can hear me well. It's a long time that I had used the microphone because of pandemic. Well, I am a doctoral researcher at the Leibniz Institute for Prevention Research and Epidemiology in Bremen. I'm passionate about nutrition, especially public nutrition, and especially in the digital media environment. My project is mainly focused on children and adolescents, and the reason why is because, first of all, children and adolescents spend the most of their waking time with digital media and social media, and second, because social media is such a powerful tool for junk food companies to promote their food products in social media. And we wanted to evaluate how the exposure to social media actually impacts children's diets and eating habits, and also to explore what are the underlying mechanisms behind these associations. For that, we conducted a systematic literature review of the all-wide studies evaluating these associations in healthy children and adolescents aged 2 to 18 years. These studies, of course, should have a social media component and, of course, also a diet-related outcome. We observed that there exists a positive and dose-response association between the time children spend on social media and their food preference, the fast food preference and fast food eating frequency, but also a dose-response relationship with sugar and fat intake and sugar-sweetened beverages. Some of the mechanisms behind these associations were, first of all, the peer influence on social media. Second, the social media influencers marketing. Third, the brain response towards the food images, especially impacting their reward and decision-making areas of the brain system. And fourth, it is about the energy density of the food that is usually marketed in the social media, which is mainly foods high in sugar, sweet, and salt. The next step is about developing a third funding project where we want to explore more of these associations and mechanisms. Thank you. If you have questions, I'm happy to answer them. You have a question, right?
Yes, just not to worry about the sound deck because it's like some we're starting some other war or something, but nothing to worry about there. Okay, so I have a 3-year-old son. So when I look at this, I say, this it intrigues me because I have an emotional connection with the subject as well. Yeah, up till now, for example, they end up using YouTube most of the time. They just end up using videos. So my question is, how are we going to measure this in a practical way? You know, like how are you going to observe children directly? What ethical issues you might potentially face? Because they're, you know, like when it comes to children and pediatric radiology studies, they're usually fraught with all these kind of issues. How are you going to face these challenges to basically reach your outcome?
That's actually a very good question, and we are actually thinking over that for a long time now because of the next step for the third-party project. Well, there exist different methods, and what you mentioned about observing children directly, of course, can have ethical problems, I would say, because of course it would be very invasive to just observe children in their everyday time using their smartphones. There are other methods such as using fMRI studies, and at least I know one study who has done this, and we might kind of incorporate the same method, like using screenshots of Instagram or YouTube where children are exposed to these junk food advertisements, and then use these pictures in the fMRI measures to observe the impact that it has in the brain, but also other measures perhaps related to taste preferences, and also relate this with answers from questionnaires. This is just an, let's say, a draft idea. We need to develop it further.
Move on to the next one. Let's see.
Thank you very much. So hello, everyone again. My name is Lars Steinert, and I'm a computer scientist and PhD student at the Cognitive Systems Lab at the University of Bremen. And in my PhD, I aim to develop a multimodal engagement-aware recommender system for people with dementia. So within my PhD, I work also with the iCare system, as Victoria already mentioned. And to remind you all, the iCare system is a tablet-based activation system for formal and informal caregivers, which provides different activation contents, for example, image galleries or quizzes, on different everyday life topics, for example, gardening or baking. And at the same time, the system allows for collecting or recording audio and video data. And so within my research, what I want to do now is to use this data. So to use the video data and to use the audio data and extract the verbal and non-verbal signals of the participant with dementia, to then use machine learning to automatically recognize when the participant with dementia is engaged or not engaged, and also to find out which activation contents are specifically engaging. And in the next step, I want to use this knowledge to improve an existing recommender system, so that the recommendations are based on the engagement. So the recommender system should recommend activation contents which are similar to those that have been engaging in the past. And what we've learned in a previous study is that engagement is actually a concept that stays or remains similar throughout these activation, which means similar activation contents actually elicited similar levels of engagement. So overall, in my research, I aim to support formal or informal caregivers and people with dementia in finding appropriate, which is engaging and likable activation contents. So, thank you very much. Do you have any questions?
Challenging question for you. You know, like how are we going to get consent here? Because you know the biggest challenge here is that you know you have someone who, like the person who is with, let's say, with the condition, who might not be able to give consent, right? Then you have the caregiver here. So who's going to give consent here? And have you provisioned for it? Have you thought about it? Just like that extra bit of challenge. Sorry.
Okay. So of course we first of all we get consent of all the participants we have. So in the current study and also in the former study, which was applied in Karlsruhe, and we get consent from the participant with dementia and from their legal guardian actually. So yeah, everything is bulletproof, I would say.
It's really worth mentioning.
Yeah.
Okay. Yeah, that's it for the posters. Like really great job, everyone. Honestly, just to tell you, we had like active. No, nothing happened. Don't worry, guys. But we had a really great active. Also 12 participants. I've noticed as well there's another slide. And is that yours, Laura? Or it is this poster? Sorry. All right. Okay, you want to talk about this? Yeah, of course you should. Like, I was wondering, like I saw an extra one.
Okay, so here is a project that is between a lot of us from ECRA, my coworker Laura, and Jasmine, Mella, Hans Henrik, and Tina. Did I left anyone else? Yes, that's all of us. Yes. So the starting of this project is that we found this is the common ground of all our topic, that we are all dealing with some sort of health app, some sort of medical app, tracking app, even tracing app. So, and we also trying to work on the grocery between our campus to find a common ground and the common understanding of what is digital health, what is digital public health. And in our case, we also want to know what is a health app and what is a medical app, because there are a lot of overlapping and a lot of times they are used as interchangeably, but by some definition, they are different. And also that by legally they are different. So this, we use the scoping review methods and we apply in the electronic search. Also, we search on the great literature in different disciplinary, in law and also in philosophy. And we use the snowball methods to make sure we can capture as much as the article as possible. And we review all of their definition, use qualitative methods with MXQDA. And here we come up with the word cloud, and you can see there's already a distinction between what people use the words to describe health app and medical app. And also we trying to develop a decision chart to help layperson to understand the difference between health app and medical app. And we are also developing one for more involved in the legal aspect of the differentiation of a health app and medical app. And we are led by Laura. So if you have any question, welcome to drop her an email or raise your question now. Yes.
So thank you, everyone. So I'll ask during the lunch break, sorry. So let's close off and let's scoot for lunch. And in the meantime, we're just going to close off the Zoom meeting. We're closing it off here, but possibly we'll try to open it again at 1 p.m. when we'll have a lecture, or rather like an open discussion as well with Professor Neville Calleja from the University of Malta, who is the head of the Department of Public Health. And he is also the director for the Directorate for Health Information and Research. So something interesting for all of you. Okay, let's go eat some lunch. Cheers. Thank you. Continue the recording a bit here. And actually, we did some secret mission because Professor Neville was actually looking at your posters whilst you were on your lunch break. So that is the best kind of feedback that you can actually all get from it. So Neville, you'll be invited if you want to go ahead literally and start giving some feedback, all yours. But I was going to suggest that you kick off a bit like telling us about you and about your journey as a public health physician as well, and your thoughts. Over to you, Nev. Cheers.
I stay here.
Wherever you want. You can walk.
So, first of all, sorry, I don't want to bore you. I hope you had a good lunch at least. Sorry about the weather yesterday. We had a bit of a disagreement, but now I think it's sorted. So should be okay. Even tomorrow, I think it should be okay. Well, maybe not to get too homesick, you know, it's sort of slow, gradual acclimatization. So, thanks, Stefan, for the introduction. Basically, as Stefan explained, I'm involved both, I have a Ministry of Health hat and also University of Malta. I'm also involved in some international work with WHO, particularly on infodemic management. I saw one of the posters there on misinformation on media. I love the tweet he chose. I can't remember who did it of you, but the chipped AstraZeneca vaccine is lovely. So I've been involved also in setting up the infodemic management strategy with WHO over the past few months and in the training for infodemic managers. But prior to that, I've also been involved in health information system assessment. So my trade, so to say, is health information rather than public health in general. I'm trained in medical statistics myself, and I've been in charge of health information in Malta. So that's sort of the health statistics and epidemiology for you. So for those of you who are not familiar with the term health information, for the past 13 years. And in fact, if I may dwell a little bit on the term health information, when we do carry out health information system assessments around different countries in Europe, first, in fact, we usually have to sort of waste, if I can call it so, some time in explaining what health information is. Well, many policymakers out there in health think that health information equals an electronic health medical records system, which is not the case. It's actually the generation, production, and use of health information in health policy. So, but why am I sort of taking time for you this afternoon? Effectively, being a small country here has its advantages and disadvantages, and I want to sort of try and explain this to you, and also to sort of make a bit of an offer to you as well. So, being a small country means that many of our systems are very centralized. So, as opposed to, say, working in Germany, where obviously you have a federal arrangement, here all systems are central. Now you might say, yeah, okay, fine, but your central systems are much smaller than our systems at the federal state level. And I would agree, definitely, we definitely can't compete with North Rhine-Westphalia, for example, in terms of size. Okay, but being centralized at a country level presents its opportunities. Why? because Malta, despite being, you know, as big as your medium-sized city back in Germany, it still has to deliver the same health information as the Robert Koch Institute has to do for the whole of Germany. Okay, so here we have the opportunity in a way, since there are so few of us, many of us have experience at multiple areas, okay? Because we still have to serve the needs of the international organizations in terms of information generation, and also certain governance systems that a larger country has to produce. Now that means that we sit pretty much on a very rich mine of data, all right, at a country level. But the analytical capacity would obviously be somewhat lacking because we invest so much in the production level. Okay, so again, seeing some of your work, it's absolutely lovely. I've seen the first poster where you're sort of trying to gauge the size of the groups and the effect of those groupings on transmission of COVID. Again, we probably, I would dare say, even though I haven't done a proper analysis, that we probably have the data to replicate that here, but we haven't done it. Not necessarily because we don't have the expertise. It might be the case that we don't have the expertise, but also because of lack of human resources most of the time to go into that depth. So my appeal to you basically is that we try to bridge this gap by opening up as much as possible our resources for analysis. Okay, so obviously I can't say, you know, if you request any data, I'm just going to give it to you willy-nilly. I mean, we need to make sure privacy, etc., is sorted out, and we do have policies in place on that, but I don't want to bore you with details. But we do, in fact, collaborate a lot with international universities to do deeper work on our data, okay? So, for example, we are working on something with Max Planck, for example, on mortality, okay, right now. We work a lot with ScienceCampus in Belgium. We work a lot with DiPH in Finland. So we feed, if I may say so, on these international collaborations in order to draw more out of our health information. Needless to say, hopefully it will also give an opportunity to you guys to develop whatever you're trying to develop as well. So I'm here primarily to sell Malta as a test hub. Okay. So we do have, so just to explain what data we're sitting on, because I don't want to promise you, you know, that we have a lot of data and we don't know exactly what it is. So we have several epidemiological registers in Malta that have national coverage. So that is, when we say national, you might say, yeah, big deal, 35 kilometers of you. But what I'm trying to say is we have a public and a private healthcare system. This might come a bit sort of as alien to some people coming from continental Europe. I understand you have a mostly social insurance driven health system. But here we have a health system which is loosely based on the old NHS in the UK. All right, so it's welfare based, provided by the public sector, by government, but then there is a substantial private sector, especially in primary care. So private sector can be a bit of a challenge to capture data. In fact, it took us some years to get the private sector on board. But I'm proud to say that for the past couple of decades, most of our data sets are capturing public and private sector. Now, when I talk of epidemiological registers, there are obviously the registers that you would usually find: mortality, births, hospital activity. cancer registry. Okay, we also have others like transplant registries, injury database, I'm trying to remember them all. Cerebral palsy, linked to the births register, we have a congenital anomalies register or birth defects. Okay, rare diseases and dementia. And I believe I haven't forgotten anything out. So those are the epidemiological registers that we have. Now, the advantage of these registers is that they are all kept, and to have the legal clearance to do that, in an identified manner. Okay, so we have an identity card number here in Malta, like many other countries do. Okay, and all data can be kept in an identified manner. Okay, needless to say, to earn that right, so to say, to justify that, and we also always have healthcare professionals in charge of those processes. The advantage of that means that we can easily link between different databases, and that's the richness. This is why I told you there is an advantage. Is this line something I'm supposed to respect, Stefan? Okay. So the richness of the data is the fact that we can link between one database and another. I also appreciate the fact that in some jurisdictions, and I'm aware that Germany might be one of them, at least in some states, this linkage is very difficult to organize. Okay? What we have done here, I'm not sure how familiar you are with GDPR, okay, the General Data Protection Regulation. GDPR, contrary to what a lot of people think, has actually institutionalized research much more than what we had before. Because what we had before, there were voluntary clauses that countries could transpose at their will, allowing secondary processing of data. Okay, what is secondary processing of data? Using identified data for a purpose which is secondary to what it has been collected for. Now, this may sound like a blatant breach of data privacy regulations, but there are specific situations where GDPR actually allows this to be done. And that is amongst a number of settings. You will find public health regulation and management of healthcare services. And this is what Malta has done, actually. Malta has actually developed its own national legislation describing these functions and the actors who can undertake linkage or secondary processing under those clauses. And basically, my directorate is one of those entities that can do this processing. So again, I don't want you to go away thinking that in terms of data privacy, we are a lawless country. There is a governance framework around it, okay? And this is, I would dare say, you might differ in opinion, but I think this is a strength for us. And I'll give you a practical example. So diabetes strategy, okay? Again, the way is very close, we all know each other. Trust me, and more need to contact someone, you and can put you in contact with the person. And that includes the Prime Minister and the President. So what I'm trying to say, so basically again, for the policymaker to pick up the phone and tell us, listen, I have this policy question, what's the evidence? Okay, that happens a lot here on a daily basis, which is nice. It doesn't always happen in larger countries where you might have the policymaker, which is really separate from the health information producer. Usually health information production is in the hands of the Public Health Institute most of the time. Okay, so you have your federal agencies like RKI, you have your regional, like a LOGD, for example, in North Rhine-Westphalia. It happens that I'm a bit more familiar with a LOGD because we had worked with North Rhine-Westphalia in the past. Here, the link is quite close. So coming back to the diabetes story, so I wanted to draw up a diabetes strategy. We didn't have a diabetes register. Okay, so in several European countries, the story usually stops there. There is no diabetes register, sorry, full stop. Okay, here we took a different approach. We had the legal framework to do it, we could do it. Okay, so we started from the National Treatment Database. We got all the diabetics from there, all the diabetics, well, save those who were on nutritional control as opposed to medical, pharmaceutical control, right? So we got the patients from there. We linked with hospital records to see how many of them are coming in for admissions, blah, blah, blah. How do they compare to the rest of the population? We linked with the surgical operations register to assess what's the amputation rate and how it's evolving over the years. We linked with the ophthalmic outpatients records to assess how many of them are getting their screening. We linked with the podology clinics to check how many of them are getting their screening. So by linking, and this is the beauty of having one identifier that allows you to link data sets between themselves. By linking, we managed, so to say, to generate a register on the fly. Okay? I dare call this a big data approach. It might not be as sexy as, you know, putting AI routines into the data and analyzing the data, but it is a big data approach. Okay, another more recent example. I'm not sure how much you are aware of sort of how the COVID pandemic has developed in Malta. When COVID broke out, March last year, okay, there was an effort by the local government to shield, like many other countries did, to shield the vulnerable. Okay, so basically, the Prime Minister came to us, okay, and they told us, listen, we would like to identify those people to whom we are going to offer an allowance to let them stay at home. So even if they lose their job, even if their employer can't pay them, they're going to get a minimum allowance to allow them to stay home. Okay? And that's precisely what we did. We looked at the literature, saw who was more at risk of hospitalization and mortality, okay? And used our databases, again, in a big data approach, linked to remove duplicates, et cetera, to identify the vulnerable patients. This was done. Patients were given that allowance. Vulnerables did stay at home. By June, because unfortunately then the system had to stop because of sustainability reasons, but by June, Malta had only had 9 COVID deaths. 9, okay? It actually was the lowest mortality rate in Europe. Unfortunately, beyond June, it couldn't be sustained anymore for financial reasons, more than anything. So it had to be stopped. But just to show you the wealth that you get when you have this possibility. Now, you might say, in that sort of, how does it change our lives? What I'm trying to tell you is this. So, and I'm willing to share also our websites, etc., with Stefan, maybe to disseminate with you. If you have queries of your own, you would like to test here, and you would like to look at our data sets, we can look into it. We can also look into linked data sets. If I link them, obviously, we would just, my colleagues. If we link them, we would obviously kill the identifier for you after linking, needless to say. I mean, you don't care who it is, you don't need to know. We also have another requirement, actually. When we give out individual data, even anonymized, we request ethics committee clearance. Because for all intents and purposes, you might still have an element of identifiability in the data. Now you might say, I don't know anyone in Malta. There is absolutely no problem of identifiability, but you have to understand that, again, in a small country, this is a possibility, okay? So if you have questions you'd like to query on data sources and you're looking for data sources, feel free to contact me, contact Stefan. Again, we're a small community. Stefan definitely has my number on his phone book. And we can try to look into helping you to trial your methodologies. I'm not ashamed to say what we will gain is deeper analysis of our data. And this is why we do it, okay? So we always reach out to students like yourselves or researchers like yourselves, I don't want to call you students, because we can generate more intelligence out of our data. I'm not sure if, sure.
So Neville, you had some time to actually look at the posters. Would you mind maybe walking us through? You can take the microphone, and maybe if you find something you want to put some feedback on,
sure.
Would love it. So.
To be honest with you, the two that picked my, my attention most were actually the first and the last. Not maybe the first, the second, the first, second, and the last. Sure. So the first one, I liked it because I must admit I felt a little bit envious, because we do have this data to try and analyze and model what you've tried to do here and trying to identify. So let me read just in case. So decision support for German public health departments by risk modeling in order to contain the COVID-19 pandemic. Okay, so again, here we have individual data, which also, thanks to Stefan, is all linked up and his team, but we didn't have the opportunity to go into such risk modeling, in-depth risk modeling like you've done here. This is a subject which is very much at heart. So misinformation on social media, I think, frankly, infodemic management is the mother of all non-pharmacological measures that we can apply. Okay, if you have misinformation, you can try whatever you like as a public health measure. It won't work because the people won't comply. Simple as that. Okay, if you have misinformation under control, and not necessarily by banning, okay, this is important. Infodemic management is not about banning. Infodemic management is about having the right information out there. Banning is an extreme measure, okay, an unhappy one, if I may say so, because it has consequences. Okay, so this I like, and I think, if I may, on this one, there's another aspect which I would encourage you to look at. Governments are not yet convinced. They know that misinformation is causing problems for them, but they're not yet convinced they should listen to social media. Very few countries have social media listening in place. And that is an area we really need to develop research on. This is related, but not COVID. So it's, I guess it's interesting as well. Some of the others, I must admit, might not be within my direct control, so to say, or rather area of expertise. I like the last one particularly because of what I'm doing, as I told you, on health information system assessments. So the last one is this digital public health index. And you might wish to know what's happening in this area at the international level. So there is a lot of interest, especially post-COVID, in health information systems around the world. Okay, so there was already some interest starting off in, say, 2015-16. And in fact, that's when I started getting involved with WHO, carrying out assessments of different countries. I haven't yet had the opportunity of doing it for Germany. Actually, Germany is very sensitive about this. They wouldn't like to do it really, but anyway, that's not on the record. But there has been now renewed interest in this capacity. Why? I mean, any of you guys are directly involved in epidemiology, or were direct, or, you know, especially in COVID-19 epidemiology? No. So nothing, nothing related to COVID-19 epidemiology, no. Because if you were involved in epidemiology before and now, there's a complete culture change, all right? So we were accustomed to take our time and make sure our data is accurate, right? And making sure that you get your information from the right source, not from any website, any pub, dick, or Harry, right? So there are very specific websites we would recommend. There should be metadata. It's usually typically complicated to consume, all right? You pretty much have to be an expert in the field to be able to understand. And most policymakers were not experts in the field. Changed completely. What do we have now? A network out there of GitHubs, making data available at almost case level data. All right, open for everyone to analyze. The best exponents, the best reporters of health data out there are people in their bedrooms, generating dashboards. Have you heard about the kids in Australia? You know the case? Okay, maybe the others don't. Okay, so there's a brilliant COVID dashboard in Australia that like all the ministers were following, right? Even at state level or federal level. One fine day on Twitter, a photo appears of these 3 teens with glasses saying, "We're so happy to contribute to the vaccine statistics today." It was 3 teens were managing one of the best COVID-19 dashboards we had in the world. Okay, so it has flipped the coin completely. Okay, so, and this is something that we need to take on board when it comes to health data. The culture has changed. Okay, and this is why I'm very interested in this Digital Public Health Index. Many of our systems might be generating data, but they're doing it either in an old way. Many of, especially of our Eastern neighbors in Europe, are still very much paper-based. All right, so I don't know if any one of you hails from an Eastern European country, but many Eastern European countries have a system of forms, forms feeding forms into forms into forms, very rigid, okay? That is not compatible with the demand for data that we have today, okay? And this, frankly, before you walked in here, I took a picture of that, so please take it as a compliment, whoever it was. I took a picture of that and sent it to WHO Copenhagen. Right, okay, so good job. Wonderful. So I didn't know that, so I'm not trying to score brownie points, okay? That is something that we're definitely building into health information system assessments nowadays, because it's very clear that that capacity means whether you're going to make it in the health information market, if we can call them a market, or not. So that's why it drew my interests in particular. The rest are also very interesting, especially the interface between digital tools and healthcare. We definitely have a lot to work on there. And again, COVID has taught us a lot. Frankly, you have one thing in your favor there. The doctors have realized that they can deliver more healthcare than they thought they could in a digital or tele way, remote way. Okay, so I think the medical profession now is more open to digital tools to deliver healthcare. So in that case, in that sense, again, I think there are opportunities. Yeah, I mean, that's in a nutshell. Please don't take this as an appraisal of any of the posters in particular. So I'm biased because of my own area of interest. But definitely good work, and congrats to all of you, because they're all very interesting. I liked also how the logout button on Facebook seems to be shifting. I never realized that actually. Yours? But did you realize then logging in is so painful? So that is definitely a disincentive to log out in the first place, even if you know where the button is. Something, if I can share also with gaps that I see in the area personally. So I mentioned social media listening. There's quite some very good tools already available, especially on Twitter and Facebook. The other platforms like WhatsApp and Telegram pose some challenges because of the way they're designed. So Telegram is designed to go undetected. It's designed that way, okay? Built in Russia, I believe, if I'm not mistaken, and designed to be, you know, under the radar. WhatsApp, again, is very private groups, so it's very difficult to penetrate. That said, monitoring Twitter and Facebook is not useless. Why? Because misinformers make an effort to cross platforms, because they're always paranoid that the social media company is trying to ban them, right? So these cryptic words, how to write vaccine, etc., etc. So there's always this drive to jump across platforms. And that helps to have some spillover also on Twitter and Facebook that you can detect. So that's good, but that's an area which has not been very well explored in infodemic management. A developing area as well is traditional media listening. So, and I know that there are some groups in Europe that are looking at analyzing sound bites, so radio clips, okay, what is being said on radio. So there's a sound to text, obviously, in some way or another, and then analyzing the content in that manner. So that's another area. The link between information and policy is something else, another area which is usually very poorly researched. The reason being that health information producers and policymakers are usually two species that don't speak to each other that much, much to our surprise. But now, again, I think COVID has bridged that gap. Okay, many health information producers found themselves censored even from publishing certain figures because it might lose an election or, you know, create major problems for the political class. We've seen a lot of these information wars during COVID. So the policymaker has definitely become more sensitized to health data. And I think that presents lots of opportunities for you as researchers to look into health and policymaking and the interface between the two. I think that's really what comes off the top of my head as sort of challenges that I see at European level and global, if anything. So I'm not sure if there are any questions or anything you wish to discuss.
So please, I mean, so my first question is, Neville, is if you're interested in opening a digital public health unit within your department. Thanks. So this is a suggestion number one, but I open the floor to you guys if you want to put some questions forward. Now is your time. Yeah, go for it. All right. Yeah. All right.
Yes. Hi, thank you for your speech. I'm wondering, what are your views on telemedicine and telehealth, and how does this look in within the projects of interest in the? Yeah.
So I think Stefan is patiently twisting the camera here and there. I'm not sure if anyone is getting an epileptic fit on the other side of the camera. Telemedicine, telehealth. Okay, so As you know, teleconsultation is something that is gaining ground. Okay, so in some health systems, it's actually reimbursed as well. So I know that, for example, some Swedish counties actually included in their healthcare package. But that has given rise to a regulatory nightmare, because where the hell is the doctor? Where's he based? Under which legal jurisdiction? I mean, he's providing services in Sweden, but where is he? He could be in the Bahamas for all intents and purposes. So, and that has kind of restricted its progress pre-COVID. Post-COVID, apart from other things. So I think in general, healthcare professions felt that the face-to-face contact is key to deliver safe healthcare. COVID has changed that, because COVID has forced healthcare professionals to deliver telemedicine, all right, and telehealth. And if you look up, I think there was a statement not so long ago by the Royal College of GPs in the UK, where the president explicitly said, we discovered we could do more than we actually thought we could. Okay, if I can reflect on local experience for whatever, you know, its use, here we had a very positive experience, especially in mental health and in family medicine with telemedicine. Not only that, actually even oncology, and I'll explain a few quick examples if you allow me. So family medicine, at first, I must admit, our GPs were very worried, because they're usually the first point of contact of the population, right? Like, half of us are going to die of COVID, you know, that sort of concern. And many of them were only too happy to switch to telemedicine. Patients also were receptive, because patients were scared to come out of the house, and they engaged with telehealth, okay? And that has worked fine. The mental health services did exactly the same thing. They moved their consultations, especially follow-up consultations, online or on the phone, okay? And I'm actually lucky enough, this morning I had one of our psychiatric trainees who came up to me for some advice on his study. We found out that we didn't have a rise in mental health encounters during the hardest part of the restrictions. We didn't have lockdown in Malta, actually. We managed to get away without lockdown. We had restrictions. At one point, we had some heavy restrictions, but never lockdown, okay? Basically, we simply tried to control the rate and keep it low enough all the time to avoid lockdown, through contact tracing, etc. Anyway, so even in the worst of restrictions, activity in mental health did not rise. If anything, it went down, because people maybe were a bit fearful to go to a clinic. But then as soon as things settled again, they came back, and so they simply postponed their encounter. So it's quite interesting the effect it has had. Oncology, last example, and I'll shut up. Oncology follow-up moved almost completely online, okay, on the phone and online. So we had an oncologist like on the phone, or even sometimes on Zoom or something that the patient can handle, and discussing follow-up with oncology patients. Remember, oncology patients were, sorry, I shouldn't say bad words on Zoom, but they were scared shitless of getting out of the, is it? Great, AI, I guess. So they were really scared of getting out of the house, and don't blame them, okay? So there was a huge risk. Have you followed that? There was a tweet at one point with multiple graphs, like the COVID wave, and then the consequences. So first you had other medical emergencies that rise, the mortality rises, okay? And then you had delayed healthcare giving rise to another curve of complications. And the final one, which doesn't come down, is mental health, right? Okay, so we were scared again in oncology of seeing this. But what actually happened was that the follow-ups went online, and the new cases between 2019 and 2020 were equal. The number of encounters in 2019 for oncology that we had here in our services in 2019, new cases I'm talking about, and the number of new case appointments we had in 2020 were equal. But that could be done by shifting the follow-up appointments online, having lots of distancing in the outpatients clinic. People felt safe to go for their first encounter at least, and then be followed up online. So sorry, I guess it was a long answer, but I think again, there have been new awakenings to the potential of telemedicine and telehealth, thanks to COVID. And these need to be investigated and studied further. Yes. Yes. Between professionals. Yes. So are you aware of the work that has been happening at EU level on that? The EPSOS project and Jason, I believe, project. Okay. So the e-health fora within the EU have been working on that as part of the cross-border healthcare. Okay. So to enable cross-border healthcare, especially, I'm not sure if you are aware of what we call the European reference networks. Okay, then I'll delve into this because it's clearly relevant to the subject we're discussing. So European reference networks were an offshoot of the cross-border healthcare directive, setting up these centers of excellence across Europe. So for example, here in Malta, we've got quite some experience with thalassemia. And we could sort of help other countries that have less thalassemia with healthcare on thalassemia, right? In Germany, for example, Hamburg, there's a center we tend to refer to a lot for brain oncology, okay? So you get these sort of, you can appreciate that some centers are better than others in certain things. And Europe is trying to sort of use this. But for this to happen, you need to have a health record that can move with the patient across Europe. Now, what's the barrier there? What do you say? What is the barrier to move a health record from one country to another? Privacy is something that can be dealt with because, again, going back to GDPR, it's one of those exceptions listed. Can we call it language? Language, literally. So I'm a Czech guy and I want to seek healthcare in Germany. The German doctor won't speak any Czech, all right? So yes, it led to semantic interoperability problems, which this group has been working on, and they've actually developed a reduced set of SNOMED. You know SNOMED codes? SNOMED is it's not a classification system, it's very important. It's very important, but I can't remember what we should call it exactly. You remember, Stefan? Standard nomenclature, I believe, yes. So SNOMED is like a system that can analyze natural language. That's natural language processing. That's the key word. Yes. So it picks up heart attack in a variety of languages and gives it the right codes in the different classification systems. And what this group has done is to actually develop like a shrunken version of SNOMED and implement it in all official languages in the EU. And that has enabled this minimum data set to move freely across the EU, wherever the patient needs to go. Okay, so there's already that work that started, so to say, for communication between patients. But yes, definitely, referral between professionals will definitely be facilitated. There's another aspect that you need to consider. I'm not sure about Germany, but I can tell you about locally. The speed with which IT systems in health are being developed and deployed these 18 months is amazing. I mean, just think about the EU digital COVID certificate. In June, it was still a document discussed in the European Parliament. Now, I'm sure all of you have it on your mobile. Exactly. If it hadn't been for COVID, we would not have reached this. I mean, you know the EU, it takes ages to do something, especially on health. All right, so again, the IT that has developed, this is like during the war, right? We started off with biplanes covered in fabric, and we ended up with jet engines in 5 years. Same here. So these are all opportunities, I think, that digital public health has to embrace and build on rather than lose the momentum. So, sorry, that took too long. Yes, you want the mic for the sake of...
I was wondering with what you said about the registries and that you can learn rapidly out of the COVID data that you gain in the Maltesian population. And I was wondering how you communicate that to policymakers, like how you implement these rapid findings into policies. Like you said, there's a low threshold communication that you know who to call. So how do you implement that?
I can assure you that no politician will listen to a message that he doesn't want to listen to, COVID or non-COVID, okay? So that's a given. So what I'm trying to say here is this. What has helped a lot was the demand, that there was actually a demand for information, okay? So the economy clearly depended on what was happening in health. So we were actually being pushed to deliver information. How does that differ from pre-COVID? Pre-COVID, we had to push information at the policymaker to try and make a decision. And most of the time they'd say, no, that's not a priority. This is a priority, okay? In this case, they were more receptive, so that helps. So I think public health, especially health information communication, requires insight to look for opportunities, okay? So you have to be a bit Machiavellian to deliver health information. You have to look for the right window of opportunity and jump on it. That's the point I'm trying to make here. It's very difficult to get a politician to listen to you unless you jump on his window or her window of opportunity. Okay? Now, how to communicate? The general maxim is keep it as simple as possible. Assume your politician is super stupid. Sorry, even for whoever is listening, if there's somebody involved in politics. But unfortunately, there are many politicians out there who are not, well, I mean, they're not qualified in quantitative statistics, for example. Okay, so fair enough. They can't digest quantitative figures. So you need to keep it simple, all right? Not all of them can handle numbers that well. Now that, as I was discussing with her earlier, can create some sort of internal conflicts within the health information producer. Because as an epidemiologist or a health information producer, I want to communicate all the background around my figure to make sure that my figure is not interpreted incorrectly. The politician won't listen to any of that. He just wants the figure and runs with it, possibly abuses of it as well, if he's that kind of person. So there's always this balance between detail and clarity, okay? I think dashboards and infographics work well even with the policymaker, if I have to be perfectly honest. And unfortunately, sometimes the policymaker actually listens to health information more if it's coming via public opinion. Now, if you guys are based in academia, you might not have as direct a connection with the policymaker like I do, being a ministry official, all right? So I could easily call up the chief medical officer and tell him, listen, we have a problem there. We need to address. That will happen. But you as an academic might not have that direct link. On the other hand, there are ways how the academic can put evidence in the public domain responsibly, and that will reach the policymaker in a roundabout way by public opinion, basically, by way of public opinion. All right. And I think I'll just tell you this and I'll close. I don't know if I answered your question or not, if I'm being helpful or not. And please tell me if, you know, I didn't. But I'll give you just a simple example of how important it is for researchers to communicate their findings responsibly. In 2018, we were very close to passing a law to fortify our flour with folic acid, with folate. I'm not sure if everyone is familiar with folic acid. It's a vitamin that, in the case of pregnancy, can help prevent certain anomalies of the brain and the spine, okay? Spina bifida, for example, etc. Now, and I don't want to enter into a controversy here, you might be aware that Malta does not allow termination of pregnancy. And as a public health community, we felt that at least what we could do is to make sure that we put in preventive techniques to reduce the risk of certain congenital anomalies where that can be prevented. Therefore, we wanted to enrich our flour with folic acid to make sure that mommy gets her folic acid around the time of conception. We were this close. We were going to cabinet with it, to the Cabinet of Ministers, which was the last stage before the law goes into action. A paper was published in New York from a professor in Johns Hopkins. And, you know, in certain academic institutions, it's the number of papers that counts. So basically, this was like a secondary analysis of some smaller part of the data set with very little power and very speculative findings, okay? But basically, she created some doubt as to the dangers of having too much folate. The secretary of the cabinet got hold of that paper before I did, frankly, I must admit, and the whole thing stopped. I challenged the researcher. I told her, listen, this is the consequence of what you've just released. I must admit that now, 2021, they've published another couple of papers trying to clarify the situation. But the momentum we've lost back in 2018 will be very, very difficult to regain, because it takes a bit of a political chemistry, so to say, to push through these initiatives. As I said, we have to wait for the next wave of opportunity to push such an initiative. So I think this is the interaction, I would say, between academia and the policymaker. Okay, so your findings need to be communicated as simply as possible. You might wish to use an intermediary, you know, within the you know, say the Ministry of Health or sort of within the public administration system, and maybe that will help it reach the policymaker. But in general, I think the maxim I would tell you is A, look for a wave of opportunity, and B, keep it simple. That's the best I can tell you. I mean, I'm not going to tell you use any sexy graphics tool to generate infographics, etc., etc. As long as you look for the right wave of opportunity and keep it simple, then you should be able to make it to the policymaker. Not sure if I answered your question or. Yes, visualizing it usually helps to keep it simple. Okay, but I'm not going to say like using Canva works better than using PowerPoint, you know, because it's not the case. It's a question of, yes, if visualizing is keeping it simple, then that might help. To be honest, and even though this is a bit maybe against the concept of public health, you might also have to take into consideration the personal background of the policymaker. For example, if I'm talking to someone with a social science background or someone who has been an activist, grassroots activity in the social sector, they might be more interested in individual stories rather than data. So you also have to pitch your message according to the audience that's getting it. If the guy who's receiving your message is someone who can digest numbers, then give him numbers. If the guy in front of you is someone who digests stories, you need to give him the numbers, but you need to maybe enrich it with a layer of stories that he can visualize and understand. So there's always that personal element as well. I like personally when I'm communicating with a minister or a group of senior individuals, I like checking their background. Because if I know that your background is a sociology background, for example, I would put in a few stories. All right. If on the other hand, if I know you're a data analyst, I know that the stories are not going to affect you so much, but I can feed you numbers. You follow what I'm trying to say? Sorry. Yes. Thanks for that question. Yes, go ahead. Go ahead. Wonderful. Allow me to repeat a bit the question because I forgot to give you the mic. So the question here is, as a researcher, and if I'm not paraphrasing you correctly, let me know. As a researcher, I have a responsibility to deliver the real findings. Okay, sort of, I would dare call it the naked truth. Okay, and then did I understand you correctly that maybe it's the policymaker that has to interpret and decide on those findings? Yes. Yes. So you acknowledge that the researcher might have to facilitate the interpretation and possibly the recommendation. I couldn't agree more with that last statement. Okay. When I joined the profession earlier on, I always thought my job is to deliver the findings. I can't put the words in the policymaker's mouth on what to do about those findings. With time, I learned that doesn't work. Okay. So I'm trying to remember, there's like a short mnemonic when dealing with a senior policymaker. Okay. You have to basically define what's the problem, what's the big deal with the problem, sort of what's the effect of this problem, and then now what? So most of the time, the policymaker you might be relating to might not be from the field, might not be from the medical field, and he or she needs help with recommendations as to how to address the problem. If he's wise enough, he won't take your word for it. He'll take your proposals, bounce them off with someone of his trust, and just say, you know, sorry, this is rubbish, but this, I think she's right. Maybe this, we can tweak it. You know what I mean? But with policymakers, you can't just deliver the naked truth and then like, bye, it's your problem now. It doesn't work that way. Okay? You have to define the problem. You have to define the consequences because sometimes they don't appreciate the consequences. Okay, so you might say, our kids are the most obese in Europe. Yeah. And what's the problem? The problem is that, you know, they'll actually develop diabetes early, they have to treat them. I'm giving a stupid example really, but, and then, okay, fine. Sort of, he appreciates why it's a problem. Now what? Okay, what can we do about it? Don't face me with a problem without a solution. That's actually the current minister always insists on this. Do not come to my office with a problem if you don't have a potential solution that I can look into. So this is something that as data analysts we need to embrace. We're not just there to deliver the info and then bye, you deal with it. Because most of the time they don't know how to deal with it. You might have to guide them, and then if he or she is wise enough, they will seek a second opinion, they will discuss it with the economist, etc., etc. I'm not sure, again, I think I'm agreeing with you, but maybe I'm pushing you a bit further on the recommendations side. You cannot just deliver the information as it is. So you have an obligation to deliver the information as it is. You will learn that you can, you can say that you hate, sorry, I could say that I hate blondes in so many different ways. I don't hate blondes, but you know what I mean? I could say I hate blondes. I could say I tend to prefer red-haired or dark-haired. You know what I mean? There's always different ways of delivering the same information. So that is then what I told you, making sure who is listening to the message, what kind of messages they are likely to be receptive to. If it's more, it needs to be enriched with stories or just data, etc., etc. Make sense? Okay. We need to close. Hey, sorry, I took too long. Sure.
So I'm just going to say bye to everyone on the Zoom call. Bye. We can't wait basically to enjoy Malta. Thanks everyone. Thank you. Well, Valletta, I guess.